Hello, and welcome to our presentation on treatment approaches for borderline personality disorder. This presentation was developed by Bridget Butterworth and Laura Johnson. We have enjoyed learning about this topic and hope you enjoy it too. In today's presentation, we will be going over the best researched and established treatment methods for borderline personality disorder. Over the years, therapies have been founded on either cognitive behavioral models or psychodynamic models. The two evidence-based cognitive behavioral therapies are dialectical behavior therapy and schema-focused therapy. Two of the evidence-based psychodynamic therapies are mentalization-based treatment and transference-focused psychotherapy. In our presentation, we will also address positive therapist characteristics for working with clients with borderline personality disorder, as well as advances in treatment. Dialectical behavior therapy, or DBT, is an evidence-based treatment for borderline personality disorder created by Marsha Linehan. Wiley described DBT as the best validated and easiest to learn of the evidence-based treatments for BPD. Another article noted, and I quote, that DBT is unmatched by other forms of borderline treatment in terms of the depth of supported research established for it. When Linehan developed DBT, she was aware that clients with borderline felt criticized by behavior therapy and often ended therapy prematurely. On the other hand, clients felt like their suffering was minimized by acceptance-based approaches. That is why she created dialectic behavior therapy. The term dialectic refers to the reconciliation of opposites in a continual process of synthesis. In this case, the opposites are acceptance and change, and the therapist alternates between expressing acceptance of the client as they are and actively encouraging behavioral change. The synthesis of acceptance and change, along with the therapeutic alliance, are core elements to DBT. With DBT, clients receive a mixture of group and individual therapy, where they receive skills training and have the opportunity to apply it with one-on-one support. Clients receive training in 4 areas of psychoeducation: mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. The DBT model sees emotional dysregulation as the core of the disorder, and each of these skills are designed to help clients improve their emotional functioning. Several studies have been done on the effectiveness of DBT, and all have had promising results. DBT has been shown to significantly reduce the number and severity of suicide attempts, as well as non-suicidal self-injury. It has reduced the rate of premature termination, as well as emergency room visits and hospital or psychiatric admissions. Studies have also reported reductions in anxiety, depression, inattention, impulsivity, and emotional reactivity. While DBT has a lot of empirical support and has been shown to be more effective than treatment as usual, no studies yet can make a strong case for DBT's superiority to other growing treatment approaches. Mentalization-based treatment, or MBT, is a psychodynamic therapy shown to be effective in treating borderline. MBT, developed by Bateman and Fonagy, views a deficiency in the ability to mentalize as the core problem of clients with BPD. Mentalization is described as the ability to make sense of self and others in terms of mental processes and subjective states. Basically, mentalization is how one makes sense of the thoughts and emotions of oneself and of others. Without the ability to mentalize, it is impossible to form a stable sense of self or identity, something that is important in order to understand oneself, one's motivations, and the feelings and motivations of others. In MBT, patients explore their own mind and the mind of the therapist. The overall goal of MBT is to improve both interpersonal and interpersonal functioning. Mentalization-based treatment is strongly rooted in attachment theory, but also integrates aspects of Kleinian theory, philosophy, and ego psychology. MBT is actually considered to be an important mechanism of change in both dialectical behavior therapy and schema-focused therapy. One article I read found mentalization to be a common factor between chain analysis, a component of DBT, and limited reparenting, a core element of schema-focused therapy. Research into mentalization-based treatment has found it to promote significant improvement in positive behaviors and functioning and decreases in negative behaviors and functioning. One study conducted by MBT's creators, Bateman and Fonagy, found that MBT significantly improved social functioning, interpersonal functioning, and depressive symptoms. They also saw significant decreases in suicidal behavior and the amount of time spent in inpatient treatment. What was especially promising about this treatment is that patients maintained and continued with steady progress 18 months after treatment. At an 8-year follow-up, 87% of participants no longer met diagnostic criteria for borderline. Just like DBT, mentalization-based treatment was shown to be superior to standard psychiatric care, but no evidence has surfaced to show superiority to other well-established treatment methods.
Schema-focused therapy, or SFT, is an adapted form of CBT. SFT views BPD as resulting from the interaction of one's genetics and early experiences. SFT believes BPD's client's early family environment did not meet one's basic emotional needs, resulting in the development of maladaptive schemas which now filter all incoming information, one's understanding of self, and guides one's behaviors in harmful ways. The goal of SFT is to compensate for one's unmet emotional needs and change maladaptive schemas. Treatment methods include mindfulness, cognitive restructuring, validation, relaxation training, assertiveness training, and anger management. However, as one article stated, limited reparenting is the heart of SFT. In other words, the therapeutic relationship is utilized to nurture unmet needs of the client as the counselor offers oneself as a parental figure. Within appropriate boundaries, counselors use self-disclosure, occasional hugs, frequent phone conversations outside of session, and imagery to reparent the client and thus change schemas. In addition, SFT counselors consult weekly with other counselors to compensate for the demands of limited reparenting. As I was reading about limited reparenting, a few red flags went up for me. I wondered about the relationships and the potential for exploitation as counselors seemingly blur the lines between professional and parent. While several studies demonstrate the effectiveness of SFT, cautious optimism is also encouraged as counselors implement this therapy into their work ethically. Transference-focused psychotherapy, or TFP, is an adapted form of psychoanalytic therapy. TFP believes BPD clients have a fundamental split in one's mind, resulting in dichotomous thinking. TFP believes events trigger either all positive or all negative affect states, which get projected onto a situation. The goal of TFP is to help clients integrate aspects of their split-off selves so they can think and act in a more coherent way. The main vehicle for change in TFP is analysis of the therapeutic relationship. TFP counselors believe a client's same pattern of black and white thinking will occur with the therapist, and such transferences are examined to help integrate the client's thinking. Therapists utilize a here-and-now focus, clarification, confrontation, and interpretation to help the client understand and identify their black and white thinking. Counselors seek to contain or hold their own emotional reactions to the client's projections, showing the client that they can tolerate negative affect states. Through this process, the client understands the relational patterns in their life and learns to respond according to reality by integrating negative and positive affects. TFP has shown equal results to DBT in most measures and is even more predictive of positive change than other therapies in anger, irritability, verbal and direct assault, reflective capacity, personality organization, and secure attachment. However, this treatment requires more intense training than other therapies and requires large doses of humility, particularly as counselors offer interpretations of transference to clients as it's necessary to acknowledge that they could be wrong. A question beginning therapists may ask when it comes to working with the BPD population is, can I even do this? While most of the literature is geared toward experienced therapists, all counselors are likely to encounter this disorder in their work, thus we need to be prepared. One article, cited at the bottom of this slide, was particularly encouraging as it described therapist qualities which build upon basic skills most counselors learn in graduate training that provide a solid foundation for new counselors to effectively work with BPD clients. These include creating and maintaining boundaries, which can be done by clearly communicating agreements of time, length, frequency of sessions, and out-of-session contact, and addressing when these boundaries are broken, repairing any alliance ruptures, which may include a curiosity about a client's missed sessions or apologizing for misunderstandings, managing countertransferences by being on the lookout for emotional reactions to BPD clients and seeking supervision to remain objective, and seeking to be a good enough therapist rather than a perfect therapist by acknowledging limitations and learning from mistakes. Beginning counselors can feel encouraged by this list. each session we can bring our best selves to the therapy room, knowing that the person of the counselor contributes to positive change in our client. As counselors look ahead to the future of BPD treatment, there are several potential changes that may be just over the horizon. First, the present demand for BPD treatment far exceeds current resources. Therefore, counselors may begin utilizing a stepped care model, offering short-term therapy 4 to 6 months, rather than the current trend of long-term therapy, or incorporate computer programs into treatment that are currently being designed to help clients practice their skills outside of session and thus cut treatment time in half. Secondly, as the implications of comorbid disorders in younger ages become the topic of more treatment studies, counselors may begin using adapted forms of therapy to meet diverse client needs. Thirdly, I found 2 studies that pointed to a potential use of spirituality in BPD treatment. One, the Not an Explicitly Spiritual study, found that incorporation of the concepts of forgiveness and justice added to the effectiveness of DBT. Another found that religious factors among a group of Muslims with BPD were associated with better coping skills and sense of identity. Both of these studies could point to a potential incorporation of spirituality for more effective BPD treatment. Lastly, and most prominently discussed in the literature I found, is a movement away from specialized BPD treatments to an integration of the common elements among all effective treatments. It is perceived that clinical decisions which draw from numerous empirically supported treatment models to meet specific client needs may be most effective with this population. Undoubtedly, BPD treatment looks promising, and counselors should stay up to date in the literature of how these advances may change current practices.